In the audience and those on YouTube, today is May 10th. This is our bi-monthly Board of Health District Health Meeting. This time I will call the meeting to order and we'll have roll call from Ada County. Let me see here. Dr. Cole, I see you on.
Yep, present.
Dr. Furch.
Present.
Dr. Young.
Here.
From Boise County Commissioner, and you're the chairman now, aren't you?
I am.
Commissioner Chairman Clay Tucker.
Here.
Trustee from Elmore County, Betty Ann.
Here.
And are you the chair?
No, but it's, next year.
Next year, good for you. Commissioner Crystal Rogers from Elmore County.
Here.
And myself, my name is El Tasbrick and I'm from Valley County. At this time, before we move on, I would also like the staff to introduce themselves. We'll start here and go around. Give us all who's here.
Don Mahan.
Russ Duke, Director.
Stephanie Myers, Division Administrator, Family and Clinic Services.
Maureen McMahon, Division Administrator for Support Services.
Jackie McLean, State Social Security Manager.
Rachel Grove, Business Analyst at the State Controller's Office.
And then I think we have Curtis online too. Curtis, are you there?
Good morning. I am here. I'm Curtis Lovelace. I'm the Division Administrator for Community and Environmental Health.
Thank you, sir. Is there anyone else online or anyone that we have not got? Mr. Beck, are you still there? Yeah, maybe stepped out. So we're going to move on down our agenda. Our next item is an action item. This is to call for any changes to the agenda. If not, I'd entertain a motion to approve the agenda. And you had a statement that you wanted to change, take off.
Right. Yes, Mr. Chair, I'd like to remove the 11:10 agenda item, discuss and vote on purchasing a medical van unit. Just to back up in time, our original proposal last fall was to purchase a Sprinter van, more of a utility vehicle, and it was to haul things to various sites. We had a number of other conversations leading up to the medical van unit. Dr. Furch has worked really closely with Ada County and with St. Luke's to possibly get a donation or some work out an arrangement paid for the unit from St. Luke's. It was an RV. He just learned, I think, yesterday that that's not going to be an option. And for all the reasons, the discussions the medical providers had about if you're going to be providing primary care and you need a bathroom and a toilet and things like that. So we stepped back, reflected on where we were going with this. And it's not never, but for right now, the utility van is what we really need for our current needs, and we'll need it ongoing. Primarily, it's going to be used by our dental program about 3 days a week during the entire school year. Then it'll be available for other staff to use, like at community health events and health fairs, where we can take a tent, set up. You're not dealing with so much with temperature issues. There's usually bathrooms available for the types of things we're going to do. So we don't. Our staff's preference at this time is not to pursue the medical van that we had talked about, and we can purchase the other van in our current budget. We have the funding to do that this year, so that carryover request will not be spent either, that the board authorized last fall. So I'd like to remove it from the agenda based on staff's preference and everything I just explained to you.
Just one quick question. Are we going to look at, what's the cost of this van and upfitting and all that? Is that coming at a future date?
Mr. Chair, so this van for our initial use, we're not really going to be adding anything to it. And if we do, it'll be pretty minor cost. It's not we're not planning to retrofit this to make it into a medical van. We're planning to use it as a mechanism to haul larger quantities of our supplies, materials, portable dental chairs, and things like that.
Okay. Any more questions before we make the motion to remove that from the agenda? No one? So I would entertain a motion then to amend the agenda as presented and then approve it.
Second.
Then I'll make that motion to remove the 11:10 item regarding the van from the agenda
And approve the rest of it.
and approve the rest of it. Yes.
And we got a second from Betty Ann?
Yeah.
Okay, we got a motion and a second. All in favor, please say aye.
Aye.
Those opposed? That's our record show there was none. Okay. So the next agenda item is also an action item. This is discuss and vote on the April 19th and the 25th Board of Health minutes. Did everybody get a chance to look at those? Any additions or concerns or comments? If not, I would entertain a motion to approve both minutes.
Motion. Yeah, to approve the minutes from April 19th and April 25th.
I have a second.
Second.
Second that motion, Dr. Cole.
Okay, we got a motion and a second to approve the April 19th and 25th Board of Health minutes. All in favor, please say aye.
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 Opposed? Let the record show there was none. And Donna, did you have it there?
I did it right there in the folder next to you.
Oh, right here. Okay, we're gonna keep right on going and maybe have an early lunch. We'll see. The next agenda item is not an action item. This is a review and discuss the FY24 financial report. Laurel, welcome.
Thank you.
Here's some of my stuff here. So go ahead, I'll turn it over to you.
Hey, Dustin, looks like you have page 3 up. Can we go back to page 1 of the financial report, please? Thank you. Okay, so this is our standard report. This report is through the end of April, which is 83% of the way through the fiscal year. Seeing all of the same trends we've been seeing throughout the fiscal year, with our overall revenues coming in at 90% of budget, so about 7% over where we expected to be at this point in the fiscal year. And then our expenditures are, as they have been, slightly behind where we anticipated being at this point in the fiscal year. For our revenues, if you're looking at the top portion of page 1, you can see that everything is coming in pretty close to planned amounts, with the big exceptions of those that are in our contracts and other category. And that's what we have been seeing this year. As a reminder on why that is, when we put the budget together for FY24, we anticipated, or we planned for some of the opioid funds to come in as contracts. Since we received those as direct disbursements, they should have been categorized in the other category. So in addition to having them plan to come in as contracts, we've gotten significantly more than what we planned, which is why you see the huge percentage there in the other column, compared to where we thought we would be. And that's almost exclusively tied to that increase amount or increase received amount in opioid funds. For our expenditures, our personnel is at 77% of the planned budget, continuing straight line increase a little below where we plan to be. Operating is at 83% of budget, so right on plan. And then capital, same as it was last month, is above our planned amount, and that is because of the IT and facilities costs. Facilities was HVAC, and then the IT cost, part of that was for the Teams rooms in all of our offices, including this that we're using for today's meeting. So big upgrades that we're able to do to be able to be more connected and have this experience no matter what office or conference room we're in. Moving on to page 2, this is our comparison of the last 2 fiscal years. These are staying fairly steady. They've been a little bit up and down compared to the last couple of years. Each of the last couple of months, we are down a little bit from where we were last year, but again, pretty close to what we've been seeing as a trend for the year. Contracts are comparable to where we were in FY '22 and below where we were last year. And some of that was opioid funds that were received as contracts that probably should have been in the other category. Our personnel costs, talked about on page 1, are under about 9.6%. Operating costs, as we said, right where we plan to be, same with trustee and benefit costs. And then because of those capital expenses we just talked about, we're over budget there. And I'll point out on this page too, Conan and I are working on new formats for this report. So if you look at the expenditures column here, we have, when we're under budget, it shows as a positive number, and when we're over budget, it shows as a negative. So that's one of the things we'll be changing for next fiscal year, just to make it a little more clear what we're looking at. That's just a holdover from the way it's been done. That doesn't, we don't have a solid reason for, but you'll be seeing a change in that for our next meeting. And then finally, moving on to our cash balance statement. Page 3, Dustin, when you have a chance, thanks. Showing a balance of just under 10 million. We know most of that's allocated to either restricted or designated. Looking at our special projects, we are starting to see a little bit more of an expenditure in our environmental health system upgrade. The good news on that is that it is officially out to bid. We had our first set of questions come in from the vendors. We'll have answers to them out by Monday, and then the bid closes at the end of this month. So also very exciting. Yeah, by the next meeting, we should have contracted with the vendor and be ready to begin implementing that new system. So haven't seen much movement in the way of what's been set aside for it, but that should be coming relatively soon, and we'll anticipate that we'll be asking to carry that special project over into next fiscal year so that we can use it to pay for it still. Employee retention is completely paid out. And then, as Russ just mentioned, the van purchase, we have the money that was set aside. When it comes time for carryover requests, the August meeting, we can talk about what we want to do with those funds and how we want to utilize that. Purchasing the van at this time. So that brings us down to our no change in personnel reserve, operational reserve, capital reserve, reserve fund designation 5.9 million, and then a restricted funds of 4.3. With all that together, we are back to a negative balance for our undesignated unrestricted. So I talked to Conan about that before the meeting, and he said that we were experiencing a lag with LUMA on contract revenue invoicing. So he said that there's been a lot of back and forth with health and welfare and having to go back and do some rework. So that is indicative of being a little bit behind on receiving in our contract revenue through the invoicing that finance is doing. Will not be a problem through the end of the fiscal year, mostly a timing issue, but it does show negative. As you know, none of that is spent money. That's all still money that we have just set it aside so we aren't in a negative balance state. It's just that we're waiting on that contract revenue to come in.
And I think the best number that I found on is on the first page, and that's our interest revenue, which is way higher
Yeah.
than we anticipated, which to me tells me that we're investing the money and doing a good job with taxpayer funds to make sure that we get the best out of it.
It's all still sitting there with a high balance. It's just that we know it's allocated for specific things. So it shows that negative balance on the cash balance. That's all.
Okay, any questions on the finance report?
Yes, I just keep going back. Are we still okay on our 3-month reserve, operational reserve? We're still okay.
Good question. Yeah, so every year when our budget goes up, we look again at what we need to be at to maintain a 3-month cash flow. So I would anticipate that at carryover time at the August meeting, we'll probably, request a slight increase in that since our budget's gone up again for the next fiscal year. Shouldn't be a big one, but there will be some.
Okay, any more questions? I guess not, and we'll move on down to our next agenda item. This is an action item to discuss and vote on an employer's portion of Social Security. Russ, I'll let you take this one.
Okay, thank you very much, Mr. Chairman, and thanks Rachel and Jackie for making the road trip today to be here with us to answer any questions that come up. You guys have been super helpful so far, and we still have ways to go. The purpose of this action item today is a follow-up from the April meeting, where we discussed a couple of options for the board to consider on what to do with the employer share of social security if it ends up being a no vote. A no vote is if our eligible employees choose to not continue participating in social security, and that's going to happen in September, the actual vote. So this is if there is a no vote, what is the board's preference? And we talked about investing in retirement, basically just giving it to the employer share to the employees in their paycheck. And then the third option was just rolling it into the regular operating budget. The third option was removed from the conversation by the board. And so now we have retirement or salary. And we did a survey of staff at the request of the board. We had 78 of our staff respond to that survey. If it's a no vote, you want it to go into salary, or would you prefer it go into retirement? 34 prefer salary, 44 prefer that it would go into retirement. We didn't get into the details, 457, 401A, it was just more what's your preference. So it's, clearly those who chose to complete the survey, their preference is that it go into retirement. So if the board chooses that today, as far as providing us direction, then we can bring that back in August, if you would like. And I think we have ideas on what we would recommend as far as what logistically would work the best. Probably the guidance we would need from you is if you would like that to be match, or if you want it just to be a direct contribution. That makes sense. So whether we would require employees to contribute in order to get that employer share for them, or if you'd prefer just to take that full amount and contribute it to each employee's in their retirement plan. So that's a discussion item. And the other thing I wanted to point out that I think is really important for our staff to know and for you all to know is this is just, even though the board today is going to say, I assume you'll vote and come up with this is what we'd like to do. It's really only as good as today, because this board is not going to be bound, or future boards aren't going to be bound to the decisions of this board. So I made sure the staff know that, you could change your mind in August, you could change your mind after the security vote, social security vote in September. You could do that at the October meeting. Health district comes on hard times, a lot of revenue. Do you want to continue to contribute to that employer share? Because it'll always be at the discretion of the board to decide what to do with that.
Question. So that would be like a one-time deposit into their retirement? Whatever that amount of dollars is. Or is this going to be an annual thing?
Mr. Chair, there's a whole host of options depending on which plan we go with, and every paycheck or quarterly or biannual. Yeah. So I think we can get into, I think what I would prefer is if that's the route we go, is certainly like Laurel and I can work together on what we think is the best option. Now, I think it's going to be, we'll need to know match or no match. And then we can try to structure it in a way that we think it's, to the best advantage of the employees with the employer share, and give you some options to vote on in August to kind of finalize. If it's a no vote in September, this is what the board's choosing at that time.
So correct me if I'm wrong, Russ, but it seems to me like what we're creating is a new benefit for employees.
Mr. Chair.
We're not going to do social security anymore. We've got to figure out what to do. Are we going to continue contributing as a match, or how's that going to work? So this is really, to me, like a new benefit.
There would be a new benefit, a change in, one benefit's going away by choice, by vote, if that's the direction the vote goes. And then in place of that, the board is choosing to utilize the money they had formerly contributed to that employee's social security to a retirement plan or to their salary, if you choose that option.
So maybe this is a question for Becky, I'm not sure, but is there a cap on what we can match?
There's different retirement rules. I don't have them all in front of me, but depending on what type of accounts you guys choose to contribute to, there's different laws that go with each type of account. So it really depends on how you guys,
Which one we get?
yeah, how you guys structure it.
Dr. Cole, you got a question? Or Dr. Ferg, somebody?
I do. So if they vote to cease the Social Security, then their half of the Social Security match, if we really didn't do anything, would just go to their paycheck. So would it be appropriate for us to just simply say all the Social Security goes to Percy instead? So we're doing the 7.5%. They're matching their original typical 7.5% and do it in a manner that, you know, whether it's monthly, quarterly, that minimizes the administrative cost to accomplish that. Is that feasible by the rules?
Mr. Chair,
Yeah.
so if you're talking about, so there's Percy base, which is what you're referring to, the actual pension, and then there's Percy choice, which
Yeah.
is what we're talking about, you know, that's the, essentially the 401k plan. Percy choice, in, you know, from what we understand, would be an easier option administratively to contribute the employer's share to the Percy choice 401k plan.
Yeah, that's what I'm talking about is the choice. But currently under Social Security, they put in the 7.5 or whatever it is, and the employer matches or does their 7.5. Can we just say, if you throw your 7.5 into the choice, we'll match the 7.5 into the choice and just basically have the net result that they would have currently with Social Security contribution?
That'd be correct. That would be a match program, 100%. You know, we match 100% up to the Social Security amount at 6.2%. So if we wanted to structure it that way, that's certainly an option. Does that make sense? 100% match. So if you put 6.2 in, we'll put 6.2 in. You put 3% in, we'll put 3% in. Or you can do 50% up to 6.2%. There's a lot of different variations to that structure.
But I think there is a cap on what employees can match, and I'm not sure, but I think it's $400 a month is the max that you can match. Is that correct?
I don't know.
Because I know in the county, that's how the counties do it. They're not paying in Percy now, is that right?
Well, all of our employees pay into Percy base plan,
Base plan.
not into choice.
Choice, right?
That's a choice.
Mhm.
Did you get that on it?
And I think, today we just want to know if the board's supports salary or, retirement. And then, as Russ was saying, for the August meeting, we can come back with, if it is retirement, here's 3 options that we recommend. And because when we have the whole list that you have, Betty Ann, it comes out to like 8 different options. Some have sub options. So potentially we could all be divided and vote on 7 different things. So if we can get the direction today, salary or retirement, then at the next meeting, we'll come back with a whole set of options and we can select again.
I was questioning why we had such a low participation in that survey out of all of our staff. That surprised me. Maybe they plan on voting yes, or, you know, something that, you know, they're not invested in change. And that's my assumption. It might be, could be, no,
Yeah, I don't know. I think surveys are,
that's less than 50%.
yeah, pretty easy.
That's good.
Yeah, right, exactly. I think depends on what study you look at and what opinion, but, and I think it may have, weighed in. I don't want that option anyway, so I'm not filling out the survey, you know, as far as the Social Security vote or
Or happy with the way it is.
happy with the way it is, right?
So the way social security is structured now, we put in a certain amount percentage rate and the employee puts in a certain percent. So right now it's a match. I mean, on paper.
100% match is what, how you describe that, right?
So that would seem fair to me.
Seems to me like the employee side is more because you're also paying for Medicare
Yeah, which is separate.
on top of that.
Mhm.
I think it's like 7.6 for the employee.
Medicare is not part of the discussion. That is still going to be paid, no matter what it is.
Yeah.
Well, that is, okay.
Yes.
We have to pay it, Central District Health has to pay it, the employee still has to pay it, so that's where,
Changing.
So that's a whole different.
Yeah,
it's 6.2%.
yes.
Employees.
That's what we're talking about.
Dr. Furch?
All right, well then, if we're just looking for a simple guidance motion, like was mentioned, then I would move that we consider the retirement option into the Percy choice in lieu of contribution to the Social Security in a matching format with details to be determined.
That's an awesome motion. Very well said. Is there a second?
Second.
We got a motion and a second to go ahead with the Percy choice option for our employees. Before I vote, I'm still a little bit concerned about the participation. I don't want to get us in trouble with the labor laws. We do this and somebody goes, well, I didn't know anything about this.
Right.
So is there some way that we could get more participation in that survey?
Mr. Chair,
I don't know. I'm just asking. I'm concerned about that.
we can send it out again, we can, I don't know how else to do it, you know, we do surveys, different surveys, obviously we have the culture survey that we did, we had, you know, I think an excellent response from that compared to some of the prior years. You know, really, at the end of the day, it's ultimately up to the board. I think what you were looking for was some general guidance from our staff. They were given ample opportunity to fill out a simple, extremely simple survey. And the fact that whatever 50 employees or more didn't complete it, whatever the board would like to do, if you'd like us to do another survey,
And interject also,
Sure.
I think some employees, because we haven't done the information sessions yet, still don't quite understand. We've done the high level sessions, but to know how to give the board direction on this if case of if their fellow employees vote no, they just don't know what they're saying yes or no to. There's also some, I think, assumption on some people's behalf that it's gonna be a yes, so I don't know that surveying the team again would bring any different results. They're looking very much forward to understanding what they're gonna be voting on first.
So my feeling is I kind of think we need to wait and make sure that all the employees understand, and you guys are gonna give them, this is what your paycheck is exactly gonna be. This is what your Percy choice is. They'll have that in front of them and then they'll know. Now, is there a timeline that we have to have this done? Did you say July?
So the vote is taking place in September.
September, okay, so we have time.
If I can say something, I would say this vote today, if we can get that information into the survey, if you do another survey, would help them make their choice a lot easier.
Okay,
Mr. Chair, the information sessions will be done way ahead of the August meeting. Lots of Q&A, we're already getting questions through our Ask the Director function. And maybe we could do another survey after the information sessions after, to the point, maybe staff don't quite understand it and don't feel comfortable voting. I think now, you know, it's 44 to 34, majority prefer the retirement option over salary of those who voted.
and I think it's pretty obvious from the board today that we want to support the employees and encourage people to save, and we're willing to match that. What they put in every month, so. Okay, we got a motion and a second stating that very fact. All in favor, please say aye.
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 Any opposed? Okay, the motion passes. Okay, the next agenda item is also an action item. In your board packet, you should have a fee policy. I hope everyone had a chance to look at that. I really like this. Basically,
Thank
because it explains in detail how we come up with these fees for all the different functions that this group does. It's not arbitrary, it's very concise and to the point, and I really like this. It explains where a lot of things come from.
Mhm.
And if there's no questions or comments, this is also an action item.
I did have a quick question.
Sure.
Go ahead. I'll let you might answer my question.
So there's actually a few changes from last year's policy, so I would like to summarize those if we can do that, okay? So let me start with, we implemented this policy last year for the first time. Our procedure prior to that was to go through, we looked at what fees were actually costing us, compared that to last year, and we had the program managers help us make some estimates on what the fee should be for the community environmental health fees. And for the clinic, we had a process that was defined, but not as clearly defined as this. So we came to the board last year and proposed this policy. What we wanted to do was set it in place, that this is basically a spreadsheet that we put a formula into, we put the information in, and it spits the fees out at us. And there isn't any room for being arbitrary or decision-making. This should be up or down based on what we know our constituents are experiencing. It's very simple. This is how much it costs us. This is what Medicaid says. This is what the RVUs and conversion factors are. What we did not include when we proposed this policy last year is when we are going to review fees. So in that first policy section, the final sentence there, fees will be reviewed annually at the May Board of Health meetings. That's an addition. We added number 5 under the procedure for family and clinic services fees, that we added in which fees we are reviewing with the board. That's the top 40 most frequently used services in the clinic, because we have so many services. Up until before last year, it was kind of picking and choosing, but we didn't have any historical record of how they had selected which fees we reviewed with you. So we are opting to use the 40 most frequently used services in the clinic. And then we also, in number 4, under family and clinic service fees, before this change to the policy, it said CDH will review the conversion factor every 2 years, but we didn't say which years. So we want this policy to be lasting, so we added that it will be in odd calendar years. So next year we'll be looking at the conversion factor again, because last year was when we established it. So those are the only changes from last year. The action item is to ask whether you approve of those changes and or see any other changes that we may have missed.
Or I don't really have any changes, but I would really like maybe a separate paragraph to explain what RVUs are, CPT, so everybody
Add some
knows.
definitions.
That's definitions.
Yep, we can definitely do that.
That loses some people right off the bat.
Yep, yeah, good point.
Okay, everybody good with this?
Well, I have a couple of questions about the methodology.
Sure.
So for instance, it says in number 4 under procedure, CDH will review the conversion factor every 2 years. Which conversion factor? Usually it's the insurance companies or the payers that establish a conversion factor, and that's usually, in my world, a dictate from on high, and then that's multiplied by the value, the relative RVU of each procedure. So in number 4, what conversion factor are we reviewing?
The CMS conversion factor.
Okay, the one published by CMS. So don't they just dictate what it is, and then doing the math and the relative value units are built on the liability of procedures, complexity of the procedures, geographic issues. What are we reviewing in relationship to the CMS? I mean, don't they just dictate what it is and we have to abide?
Yes, so what we mean by reviewing it every 2 years is that we won't make a change to the conversion factor that we're using in the in-between years. So if there's been a change between 2023 and 2025, we'd implement it next year. So it's just that we are going with what they dictate on a biannual basis rather than making a change to the CMS conversion factor that we're using to establish the fees annually.
But
Those
don't
factors
they,
change from year to year.
Stephanie, you would be the one.
It depends. Sometimes they change 4 cents 1 year. And then sometimes also work RVUs change. So some don't change for years and years, and then there might be one that goes up a significant amount. But the CMS conversion factor doesn't change by a high amount. So I think in looking at it, the previous year, it was 4 cents, so there's no point in redoing all the fees just for 4 cents change in a lot of fees, unless that was the board's job.
Does that answer your
But-
question, Doc?
well, maybe not quite. So so I realize that sometimes it's a minimal change, but sometimes they're more substantive. Can we end up afoul of the regulations? Because in my world, if I bill more than the Medicare allowable based on their new conversion factor and the new RVUs, I mean, it's punishable by a $10,000 per line item fine. If we're only reviewing once every 2 years, but there was a substantive change in between, can we run afoul of, CMS rules?
Yeah, go ahead.
So Medicare is the lowest reimbursable rate. So let's say for a venipuncture charge, we're charging $15. That does not mean Medicare has to reimburse us for it. They pay us at the allowable expense. So if something were to change, they would only pay that allowable. I have not heard that you get in trouble or fined because you bill an amount that may be higher.
Okay. Well, maybe it's different in that world because I have on all of the Medicare procedures something called the limiting charge. And if you bill the patient more than the limiting charge, it literally is a $10,000 per line item fine or a year in prison if they prove intent.
That's
And
called a vacation.
yeah, it'd probably be a lot less paperwork there, but anyway, maybe I'm just extrapolating some of my world into something that doesn't really apply here with CDH. I don't know who the designee is there to serve the prison term if we run afoul, but
Not the chairman.
I think it is actually.
the director, the chairman, it's got to be one of the two of you.
And the biannually is actually more frequent than what most of the other health districts are doing. When we put the policy together last year, some were reviewing that were changing their conversion factor. They had their board decide on the conversion factor that they were using and we're setting it for 5 years or more. So we feel like we're establishing a reasonable rate that works with our business needs. And no, we're not, as Stephanie said, we're not running afoul of Medicare, Medicaid.
Okay. And then if I might, one more question on item 5 or line 5. It talks about, which is the line where the major payers were consulted? Oh, 3, I guess it is. Is that for like standard insurance, or is that payers that have like a true blue or one of the Medicaid, Medicare crossovers, or Blue Cross crossovers?
You got me on that one.
I actually don't think we had to use this yet, Dr. Furch, because most of them had a Medicaid reimbursement rate or had work reviews, so we didn't run across something. The only one that we had that we couldn't figure out was like a sports physical, which is not even covered. So even by Blue Cross or Aetna, that was the only one to my knowledge that we weren't able to find a fee with. And we also could not do it with the highest insured business from the largest payers. I think we just wanted to put in that scenario, if those other two options, we were not able to find a fee, that would be the next step we would go. And I don't have what our third largest payers are. Off the top
All
of my
right,
head.
because sometimes what happens with third-party payers, if providers only bill what they allow, then through their metrics, they never end up raising their rates, because usually they use a usual and customary methodology, do these averages, and if no one ever bills more, you know, as a contract provider, they'll usually knock off 30-some% off of usual and customary, and if no one ever raises their fees, then there's never any pay increases, which can be challenging. A lot of providers just bill what's allowed, and that ends up backfiring, and that's why the Blue Cross can build a Taj Mahal and the providers are making what they made 20 years earlier.
So Dr. First question, is that something that gets changed in the legislature? Is that a legislative function? I don't know.
No, I mean, well, I mean, I'm not a fan of legislature price fixing or getting involved in that. It's just kind of a free market contracting thing, but you know, there's certainly a disadvantage to providers because providers are precluded from getting together and cooperating, because then they get prosecuted for collusion. And up until the last couple of weeks of Trump's administration, health insurance companies had a special exemption from the antitrust collusion laws, so they could get together and set fees and policies, but providers were precluded from doing something similar. So there's a disproportionate amount of power between the actual contracting providers and the payers, and especially now with Obamacare and the payers receiving hundreds of millions of dollars in taxpayer subsidized premiums that prop up that system. Providers end up at a disadvantage, in my opinion. And so if a provider only bills what is allowed by a major payer, then there's never any escalation that is then reduced by the 20, 30, 40% off the usual and customary. So that's my concern, is that we're just simply using what they allow as opposed to what's a fair market fee, and then the insurance companies reduce based on contractual language to the contracted rate. So I don't know if I muddied that all up, but if everybody understands that.
Yeah, but you would think there'd be some way that providers could get together and say, hey, we're losing money on this particular function. How can we increase those rates? And it sounds like they don't even let you do that.
Mm-hmm. See, it's generally community hospitals, county hospitals and stuff all over the country are closing because they're not getting reimbursed from payers at a rate that even covers the overhead of the procedures they're delivering. And so much to do is being made about, you know, certain things in Idaho, but that's literally happening all over the country. Smaller hospitals aren't able to withstand the overhead with the lower contracted rates that don't provide enough to even cover the overhead of the procedures being delivered. So that is my concern, is just that we're using the methodology that makes sure we get reimbursed from those payers at a sufficient rate.
Okay, well, it sounds, I guess the only thing I could say there is maybe if the conversion rate changes drastically in 1 year, I'm assuming the staff would come to the board and say, hey, we've got to raise fees, or this is what we need to adjust, or we don't want to take a financial hit. But at least, I think we're a little different than the providers in the fact that we're not trying to make extra income.
Right.
Trying to provide a service. Okay, is everybody, any other questions?
I did have one more question. Just like at the county to raise fees more than 5%, I think we have to hold a public hearing. Is that not the same here?
Mr. Chair.
Yeah.
There's a section of Idaho code that the board can charge a reasonable fee to cover the cost of delivering a service. So it's not set by a percent, but that's why we're trying to keep dialing this in to figure out what is a reasonable cost associated with that. And historically, there was more subjectivity built into it. So we're following that requirement in terms of setting our fees, and then we dialed it in even further by creating a policy so that staff leave and we're trying to scramble to figure out what we did 2 years ago. We have the policy in place, reviewed by the board, approved by the board. You all know exactly what we're doing, and then the public certainly would know exactly what we're doing. And then last and probably most important, we know what we're doing from year to year.
Yeah, it's the same in the counties. The history of what was done in the past is lost when we have changeover, new people. And sometimes people go back and try to do something that you tried 5 years ago that didn't work. So the history is really important.
So we're not capped. We don't, and essentially these are public meetings. We have the public comment period. Individuals can see, post the agenda if they want to put written comments in. So we try to be, transparent about it. We're not just modifying it mid-year, but good question.
Yeah, good question. I think, you're gonna find as you become more involved with the county stuff, they really restrict the counties more than anybody else, and even over the cities. And it's like, picking on us, but it is what it is. So this is an action item. We need a motion and a second.
So I have a good question.
Sure.
Who negotiates the cost contract?
Mr. Chair, MedMan was our billing company, but we usually don't negotiate. We've talked about this a couple of times where our payer mix is mainly self-pay patients, and 20% or less are insurances. So we don't spend a lot of time negotiating it. Whatever work review rate they give us, we just leave for.
That answer your question? Okay, we're good. So then I need a motion to approve this fee policy.
So moved.
Do I have a second?
Second.
You got a motion and a second to approve the FY new fee policy. All in favor, please say aye.
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 Any opposed? We have one opposition. Okay.
I don't think there was an opposition.
No.
Oh, was that an aye for or
Aye.
against? Doc? Okay.
I
thank you.
said aye.
So majority approved. Now we're gonna go on down. It should be in your packet of new fees. This is also an action item, the FY 25 fees, and I guess the only thing I saw differently was,
Some vaccines.
vaccines and
Yeah.
there was something else.
Venipuncture,
Right?
the top line item on the.
Yeah, venipuncture was, I wanted to make sure that wasn't a typo. It is 15.
It is 1542, the Medicaid rate on that went up significantly. That's when we don't have an RVU for. And then the two other vaccines for the COVID vaccines, which we were getting federal money to administer. And now that is not there, that's the cost. So it is a significant increase for those two. and less significant for the venipuncture. And then, yeah, our community environmental health fees, very minimal changes to those. The few of them went up $1 to $8, but no big changes using the new formula, which we were glad to see it. Some reassurance that it's working. Our cost to perform the services have stayed the same year over year. So we are happy with the way the policy is working and how nice and easy it was to put it together using that.
Yeah, I'm glad that land fees and the sewers set up sewage didn't do it,
Yeah.
because that's the number one complaint I get as commissioners, that charge. But I did have a question on child inspection, child care.
Mhm.
Those are actually set by code,
Mm-hmm.
so we don't have any authority to
Do not,
reduce those or anything.
no,
I didn't know that. Because I feel like those are a hindrance to people starting a new daycare, or some of those fees. If it's set by code, we can't change them. Okay, any questions on this?
Is there any guidance, or why did the fee for administrating the COVID shot double? Was there something specific that, or is there any information as to why that specifically jumped up so much?
yes.
Which one is that?
It is, I should have numbered these, what, yeah, I couldn't find it. Look for the ones with the bigger changes.
9,132. It's like, it's the bottom.
Yeah, there's two.
There it is.
So there's 87, oh no, that's.
It's 90480 is the CPT.
90480 and 91322, both those are associated with COVID, yeah. So, for last fiscal year, the when we were getting the federal money in, for the vaccine and for the administration, so we weren't charging for it. So we used our actual costs to perform it, for the fees that we presented last year. Now there is, an RVU for it and the conversion factor. So this year it's by the formula that we use, the policy, and last year, there were not numbers for those. So then we're getting the federal funds to provide the vaccine.
Oh, go ahead.
That.
I have a question. Yeah, I have a question as well. Is CDH still offering those shots? And my question would be why? Because it's a product for a variant that's extinct. So it's not without risk in terms of physiologic reactions. So it's an extinct product, an expired product for a variant that doesn't exist. So I think this would beg further discussion as to why, if we're, interested in the health of our communities, why we would be offering something that's 100% risk with 0% benefit at this point. So I think there's a bigger ethical and medical question involved here beyond a fee.
So my question, Dr. Cole, because I don't know, is there a new updated vaccine?
That's the lie we've been seeing in the media since March Madness and since the Super Bowl. You hear updated shot from, Pfizer and whatnot, but the variant which they cover went extinct, months and months ago, and we're on to the K.1 and K.2, and the antibodies formed from the earlier shots are completely escaped from the current variants. Everybody's going to get the new ones. There'll be a mild cold at best based on, what we're seeing with the evolution of the virus. But literally, these injections have zero benefit at this point and do carry risks, especially in the under 65 population, and even more so in the pediatric 0 to 18 population, where there's in fact, Cleveland Clinic just came out with a study showing what we call negative efficacy. The more shots you get, the more you actually suppress your immune system and get COVID more often. And that was a 50,000 patient study of Cleveland Clinic's employees. So, my question is just more a medical ethics question of, if we as an entity are still suggesting something that, again, is essentially an expired product.
Well, I think that's a very good point. I guess My thing is that if people come in and want it, do we have to provide it? Even though we know it's not effective anymore, maybe it's, you know, grandma just wants to make sure she stays updated on her boosters or whatever. I don't know if I want to take it out. I don't know how to handle that.
Yeah, I mean, again, from a medical point of view, I think we need to be honest with the patient. It doesn't cover what's out there. And so I think transparency, you know, trust in society, trust in politics, trust in family is very simple, and that's just truth plus transparency. And so I think, you know, being truthful and transparent, well, certainly you can get the shot, we have it available, but it doesn't cover what's out there now would be, I think, a policy that would be prudent and honest to the patient population we serve.
Yeah, I guess what I'm wondering is what the kickback would be if somebody came in and wanted a COVID shot and we don't offer it anymore.
Yeah.
Well,
good question. I personally would tell them, well, we have the shot, but it doesn't cover anything. It doesn't cover what's out there, and it actually runs the risk of altering your immune response for future infections based on major clinic studies from major American, you know, one of the top 3 institutions in America has shown that. So I don't know. It's an ethical dilemma. That's why I just wanted to bring that point up.
And it's a good point, Dr. Birch.
Of course, one of the healthcare premises is first do no harm. And so the obligation, I mean, literally the concept is the first thing you try not to do is harm somebody. And so if there is a procedure or a product that is now passé, our healthcare obligation is to make sure that we're not in any way harming anybody. Numerous things, multiple pharmaceuticals have been pulled from the market because they were harming, you know, lobotomies have fallen out of favor, numerous things like that. And so my response to your question, Commissioner, would be, well, we really do have an obligation in that regard, not to harm people. And if that's what the science is suggesting, that it is a net harm, at the very least, we have to have complete and total informed consent with the inclination that we're not going to do something that is harmful to the population.
Anybody else want to weigh in on this?
Yeah, I would just ask what CDH policy is on. We have a written policy that says basically what do no harm, but I don't know. Is there some sort of policy already in place to cover their concerns?
Mr. Chair.
Yeah.
So what we have always done, and same as the other health districts around the state, is offer the vaccines that are recommended by the Advisory Committee on Immunization Practices. It's a large national organization. It's organized under the Centers for Disease Control, and there's vaccine information statements that are to include all vaccines have risk, some risk, and we provide that to all the patients, or in the case of children, provide it to the parents so they can make an informed decision. Now, does it have citations from the Cleveland Clinic study? It would not.
And to that point, Russ, you know, I listened to that entire last ACIP committee, and at this point, you know, they recommend for only 65 or over. But if you sit and listen to one of those entire meetings, you can bring in all the adverse and risk data and harm data in the world, which some people tried to do. And unfortunately, the regulators are highly captured by the pharmaceutical industry itself. And even if you came with, you know, thousands of deaths and thousands of harms, they still vote yes. And thankfully, it's 65 and over, so, you know, they don't recommend it for under that age. I personally, with Dr. Furch, along those, you know, that oath we take to do no harm, wouldn't recommend it to anybody at this point, but I have a deep understanding of immunology and virology. So the ACIP committee I know earlier last year or year before we voted, we would vote first whether or not to follow CDC guidelines. At this point, with the genetic injection and watching AstraZeneca get pulled off the market in Europe this week, because they know, risks plus they're not keeping up with variants. Again, I think we can be a leader in at least protecting our patients. If it were something that were beneficial, look, I'd be all for it. But at this point, I understand historically that policy, but ACIP, if you listen to that last meeting, it was a circus of the absurd. So I just want to make sure we're aware of that. And these are things I do follow very, very closely. It's been a matter, obviously, I've been concerned about for many years, but just wanted to bring up those points. So I'll defer. Thank you.
Anybody else? Staff?
Presenting fees. I said, I'm just presenting the fees. So.
I think the interesting thing is, okay, if we decide to pull out of the CDC recommendations, how far do we go? We end up turning ourselves into a more of a political group than we do an actual public health group. And that's my fear, is that someone else may come in years down the road and say, well, flu shots are not good for you either, or pneumonia shots because it's a new variant or whatever. How far do we take this? My feeling is, if someone wants to come in and get a coronavirus shot from us, we should be able to provide it. Because it's their decision. But maybe I'm not a doctor, I'm not a medical guy, so I don't know the ethics.
Well, and as long as there's informed consent, I think that's the key. If there's informed consent, and so, that's the important aspect here. Are they informed that the current shot doesn't cover the current variants, and that there are some risks? Again, people can go in and get all sorts of plastic surgeries and elective procedures as long as they're informed what the risks are and the patient opts for it. You are correct, but they need to be informed. But at the same time, they need to know the potential harms up front as well.
Maybe we can review some of the documentation that Dr. Cole's referring to before the August meeting and still vote on the fees as they stand, and then have a review of.
Yeah, I think we should approve the fees today, get that part done, and then come back and look at taking that clear out of the list.
And I can bring you all the data in the world. I'm writing a book on this right now, so I have thousands of references, and it's written in a layman's language. You don't have to be a medical provider to understand it. So I will, my goal is to have that done by July anyway. So I will have basically an outline for you. I agree. Let's just vote on the fees today, and then beyond that, let's make sure we're doing things that benefit the public health-wise. Thank you, Mr. Chair.
Thank you. I appreciate that. So then, if there's no more questions, this is an action item. I'll take a motion in a second to approve the new updated fees.
Move we approve the new updated fees.
A second.
Second.
Got a motion and a second to vote on the CDH new fee policy. All in favor, please say aye.
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 Any opposed? No, fees, yeah, I'm sorry. Yeah, the 2025 fees, this is for that vote. So we got a majority vote on the fees. And the next agenda item has been removed from the agenda, so we're gonna go right to the director's report.
Thank you, Mr. Chairman. So that's one item, there's three items I'll talk about. The one item that's on there is just a reminder, as you guys plan your fall, that the Idaho Association of Local Boards of Health, for the first time in longer than I've been at the health department, changed from a June meeting to an October meeting. So it'll be hosted by Public Health District 7, and it'll be in Idaho Falls, and it'll be on October 23rd and 24th. So again, you have a lot of time to think about whether you want to attend or can with your other commitments. But if you can attend, I think it's worth worthwhile. I know many of you have been on the board, have attended those meetings. It's the one time a year when you can get together with the other 6 boards of health. Some of them have a few more members than us because they have 8 counties, and talk about things like resolutions, just like other, medical associations and other groups do around various topics. There's usually educational sessions, and then they do some evening activities. One of the evenings, so a social opportunity for you to get to meet people in the same position you are here for Central District Health. So I encourage you to go. It's covered by the health district, and you get your daily, call it honorarium or per diem. You get your per diem. Yeah. So
I was having trouble hearing. What's the location and date on that again, please?
So it's October 23rd and October 24th, and the meeting will be in Idaho Falls.
Okay, thank you.
And that's the headquarters, the main office for Public Health District 7, Eastern Idaho Public Health District.
And I assume they're gonna send out hotels and all that kind of stuff here pretty quick.
Correct.
Time this summer, so we'll know where to get rooms and all that.
Correct, Mr. Chair. And Donna will make sure, as always, you get that as soon as it's available, and then she will help make whatever travel arrangements that you would need. So speaking of, then there's documents called resolutions. So resolutions are policy statements that local boards of health can bring forward. Usually it starts in one board and it gets shared with the other boards, and then it's brought before the full body to vote whether or not we want to pursue some type of policy change. So in the past, been on issues like the food establishment license fees. We want to increase the food establishment license fees. We want to take it out of Idaho code and want local boards of health to set those fees. So it really sets the direction of local public health and the things that are important to us that may influence, for the most part, legislation. That's what it comes down to. So this will be a little closer to the legislative session, but we've, I think through House Bill 316, have moved ourselves further from having to go through the governor's office and Division of Financial Management. We find our own sponsors and moved bills forward. So think about that. If there's anything that is on your mind that you would like to be discussed at the full association meeting, you can send those ideas to me, and I can work directly with you if it's a topic I need some help on, or if it's things that we can do our own research and bring back a therefore be it resolved statement based on all the whereas statements. I'm sure most of you have seen resolutions, and well, if you've been on this board, you've seen plenty of them. So anyway, so that's coming up. So if you can attend, great. If you have resolution ideas, bring them forward. I'll draft them for your consideration at the August board meeting. That would be a good time to get that done, and then we can share them with the other, I'd share them with the other directors to share with their boards. Topic number 2. So there's one private municipal landfill in the state. There's a lot of county-run municipal landfills in the state. Happens to be in Commissioner Rogers County.
The winner is lucky.
The winner is.
Lucky.
Yeah. So what ends up happening is we have Central District Health has, by law, regulatory oversight to make sure they're following their operations plan, things like daily cover. The leachate coming off the waste piles, and in this case, it's just a large dome of dirt.
Out of regulated.
Right. And then they have some challenges with some waste tires that need to be processed a certain way. Anyway, I think the county certainly has been a little bit frustrated as far as on the enforcement side that ends up being really in DEQ's Department of Environmental Quality's area of responsibility. If we're to do enforcement, it's going to be very expensive, and the county doesn't have the money, we don't have the money, and I'm not saying that the state would have the money to take that on either, but somebody has to enforce it. There's rules that you have to follow. We're in charge of making sure the landfills are operating according to the approved plans. And then when they don't, that's when you tend to get into the challenges and litigation and what have you. So I bring it forward because it came up at the meeting, Betty Ann
County.
attended, where we did the budget presentation like we did at all 4 counties. And it's a big deal. And I think other counties are actually looking at that right now too. They're dealing with their landfills are full and they're having to transport waste in North Idaho all the way to Montana. So I'm not sure what the solution is, but it's a point that we're going to bring up the directors. We've talked about it. We think it's worth having a conversation. I don't know about a resolution, could be, but having a conversation when we meet in October. And we're going to invite Director Jess Byrne. He's the director of DEQ to attend that meeting and provide a presentation from their perspective. There's always a political aspect to these types of situations, and he can maybe share more insight because he's a direct report to Governor Little. The last question
is we contract with DEQ to do this service, is that correct?
Mr. Chair, no, we do it. So our staff, like Jason Foley, who I just saw walking out here, he looks at your transfer station.
In charge of enforcement as well.
There is a responsibility for the enforcement component, and that's where it's kind of been back and forth between DEQ, who really is in charge, who has the authority, and who has the money to do that. So that's where I think we need to have conversation and clarity on who's responsible. And I think, just thinking about the comments that I heard, there's frustration with DEQ not taking the enforcement action in a timely enough manner to move these decisions along. And it's really our role with we're public health, and it's potential to impact public health. That's why we're doing this work. So, yeah.
Yeah, there's a lot of violations and deadlines, but then once those pass, there's no, follow-up action as far as DEQ went. So it's, in our case, it had to come to our commissioners, but we had to shut it down in order to get action taken. Which is a huge burden, legally and all trash. Yeah. So, and it's just frustrating.
I was under the impression that DEQ was the muscle behind what we decide.
If they don't flex the muscle, it's not much muscle to be had.
No, it makes the whole model weak.
Mm-hmm.
Yeah,
that's going to be a good discussion. I can tell you right now, there's 5 counties: Idaho Valley, Clearwater, Lewis, and Nitz-Percenting. We're working on a regional landfill just west of Grangeville. And it's all, we've got an option to buy, I think it's almost 1,000 acres. And we're just in pre-study kind of stuff right now, because all those counties there haul their trash to Missoula, Montana. And the long haul costs, well, for instance, in Valley County, we do about usually 3, sometimes 4 trucks a day at $1,200 a truck load. So our solid waste budget is moved up to $3 million just for our testing. And we're spending it all on trucks and tires and fuel.
I may stop complaining.
And this is a good infrastructure planning that we all need to do to make sure that we got the future taken care of. We thought we had a deal going with Adams County, a regional there, but there was a change in leadership in the commissioners, and they just came out and said, we're not interested. It's ours and ours alone. So that kind of changed that whole.
Yeah, I have to give kudos to the Twin Falls County Commissioners because they're tolerating our garbage, literally.
Yeah,
currently,
yeah.
quite a bit.
So it's good.
And Ada County as well. Yeah, we're going to Southwest region.
Yeah, watch those long haul costs. And then when you get it there, you still pay tipping fees.
Mhm.
So it's pretty spendy for a load of trash. Okay. The only thing I was gonna talk about the resolution side is the fact that you guys remember we pay IAC to represent us at the legislature to the tune, I think, of $12,000 a year.
Combined all 7 districts.
Yeah, for all 7 districts. And my thinking is if Dr. Cole and Dr. Furch come out with information about the coronavirus vaccine, and maybe it's not something that we want to do anymore, that might be your way to run this through all 7 districts as a resolution. I think if all 7 came with the same feeling, it would certainly have a major effect on, legislation at the House, the Senate. That's one way you could approach that. Who knows how far it would go, but that might be some of a resolution to consider. But I think first we've got to decide on this board what we want to do, and we'll know that here September when we meet again. So September.
That's an idea. Thank you. Yeah, I'll work towards that. Thank you, Mr. Chair. Appreciate it.
Okay. Anything else?
Yeah,
Could you say a few words about the potential that we heard about last Friday about the bird flu, whether we've had any documentation? Maybe Dr. Cole or Dr. Kirch knows, is the bird flu transmitting to humans now?
There have been 2 cases that have resulted in pink eye and a runny nose. Bird flu, yes, is rarely transmissible mammal to mammal unless it's tinkered with in a laboratory through gain of function. It is the big scare and has been the big scare for decades. Obviously, there are strains of flu that circulate every year that recombine, the H5N1, that's the big concern. Again, this is the problem of using an overly sensitive test that's actually, technically they're using a flu A test for an H5N1 virus, which is not proper. It has shown up in the milk of a couple of dairy cow herds. It is not highly transmissible to humans at this point. So, do we need to be prudent? Are there early medications one could get on board if one were to get sick quickly? Certainly. There are 3, BARDA from, the federal government has developed 3 vaccines already that are non-RNA virus vaccines, or non-RNA based vaccines. They're traditional protein vaccines. So there are available interventions. One would have to vaccinate before an outbreak. It is not high risk to humans at this point. Two human transmissions, and the symptoms have been minor at most. So I think, is it a concern within the veterinary industry in terms of flocks and industry? Certainly in terms of the commodities impact that it can have there within the animal realms. But we need to be aware and prudent, but I don't think we need to be highly afraid.
Mr. Chair, and I had sent that came up, I hope you got the document, I sent it, it was kind of just a quick Q&A from our team, so just exactly what Dr. Cole described. It's not high on our list, but we are monitoring it because that's part of what we do, and have plans in place with the Tamiflu product, as I understand it, is one that you would use as the treatment if it does create more issues for people. I guess it's quite deadly to cats, is what my staff told me. So if they get it around dairy farms, they don't do well. I know that's going to make a lot of you sad, but I guess that's what's happening.
Well, it sounds to me like it goes back to the original problem with the concentration of feedlots and dairy cows in such great numbers that it's just a cesspool for all this kind of stuff. And I don't know how you're going to get away from that business model, but I know that in the cattle industry is really good right now. It's very profitable. And there's a lot of guys that get in when it's high and then it crashes and sell when they're low and they can't figure out why they don't make money. But cattle business is pretty good right now, but I don't know about the feeding industry with the rancher's finally making some money, so that's a good deal. Thank you for the update, Dr. Cole.
Yeah.
Thank you, Mr. Chair.
Yeah, Dr. Cole, I was just gonna say, as you know, as a board member, if you're probably watching this on a national and global level, I think our staff are to some extent, but if you hear anything, please do let us know if there's, it becomes some concern, so just in case
Absolutely.
we don't see it. Okay.
Yeah, I meet with physician teams weekly from around the world, so I will keep you updated. Thank you.
Awesome, thank you. So one last quick item on the landfill issue. The another thing to consider is if it would move, like public health districts are gonna enforce and we're gonna establish budgets for it, we're gonna be enforcing against, in our case, 30% of our budget contributors. So there's that little dynamic that can't be forgotten. I'm just saying.
Planting the seed, that was the one thing to see.
Right?
That's a nice way of saying, don't buy the hand that pays your bill.
Yeah,
Yeah.
so, again, there's political aspects, obviously our primary concern is public health, so, and we want to protect our community as best we can, whatever angle it comes from. Senate Bill 1329, I brought that up before, it did pass, and that is requiring consent for minors receiving pretty much any types of healthcare, preventive healthcare, mental health services, and it's as often legislation, it's not extremely well defined what that looks like. So the health districts have been in communication with our legal counsel, who's Mike Kane. He represents all 7 districts on subjects like this, but there's still some uncertainty. There's laws out there for communicable disease, 14 and older. You can consent for your own care. For substance use, 16 and older. Those laws still exist. You got the new law that may override those existing laws. It gets down to things like handing a condom to a 17-year-old. Is that provision of healthcare? And it's like, well, it's preventive care. It prevents pregnancy, prevents sexually transmitted infections, and you need parental consent to do that. So that law goes into effect on July 1. I'm sure all healthcare providers are kind of struggling with that. Generally we would get consent for almost everything we do, but there are things that we haven't always required, encouraging and what have you, or there's certainly those conversations. So I'm not sure where we'll land. I think there's certainly a desire for the 7 health districts to be on the same page, but that might be another resolution conversation you want to have for October. I get the point of the bill, but all of us have been around a while. Sometimes bills get passed and it's not quite, it's a broad brush stroke that misses out on some important elements that might be more harmful than helpful for our community. So just wanted to put that out there again, and again, thinking about resolutions, if you have thoughts, especially from the healthcare perspective, it's Senate Bill 1329. I'd encourage you to read that.
So Russ, if you're a 16, 17-year-old kid and you go to the pharmacy and buy condoms, they have to get permission from you, kind of.
Mr. Chair, it's one of those things. It's how do you interpret providing healthcare services? And you have a whole list of what that means without any specifics, but part of that list is preventive care. So if you're a healthcare provider, a pharmacist is certainly a healthcare provider, what that might look like for them. So I don't know. Mike has his opinion. Kim Stanger with Holland and Hart, he has, I think, a bit of a different opinion. So, what we don't want to do is we don't want to be part of case law to make that. So we're trying to get our thoughts around this and get our practices in place before this goes into effect, but it is right around the corner. But I'm feeling we're probably going to definitely start off with a more cautious approach. But I think there's maybe some good intentions behind this, but the unintended consequences are, we're all just scrambling to figure out what this means.
In the meantime, STDs and teen pregnancy will go up.
Good.
Seems to me like they should have been more specific on the bill of what they were talking about. Another big paintbrush that
Yeah.
gets a lot of damage. Okay, anybody else have anything for this meeting? Curtis, you've been really quiet.
Yeah, no other comments. I appreciate the input on vaccines and fees, so thank you.
Okay, is there anyone online from general public that has comment? Well, I'm gonna go open the door and see if there's anybody outside.
Mule deer on the front porch if you want.
Yeah.
Some on the way.
Okay, before I adjourn this meeting, when is our next?
August
16.
16th.
It's on the bottom of the agenda. Okay, if there's no other business before us, this meeting is adjourned. Thanks, everybody, for
Thank
showing
you.
up. Good to see everybody. Thank
Thank you.
Yeah, take care.
Yeah, you see that ball.